Hi, I'm Dr. Donato. Welcome to my channel, Ask Dr. Niven. That's AskDrMiven. We'll be covering different topics on cancer once a month. On the second Tuesday of every month, we'll be covering different types of cancer. And today we'll be talking about breast cancer. That's a very common cancer type that I see in my coaching practice. And I'd like to cover a case that will be an interesting case. And so we'll go through different documents that I'll be showing you. And I will uh, make a change on names, the patient's name, and also the age. Everything is different. And the client has given me a permission to share this information, but there's really no names and no uh, identification that will lead to who that person is. I'm going to just make this person as Mrs. John Doe. So I'm going to be sharing this information shortly. But first of all, let's talk about breast cancer since it is a very common cancer, probably the most common cancer I see in my coaching practice. And so let me give you a little bit of a background on a typical breast cancer case. Usually, the individual is quite concerned about doing conventional therapy, and one would like to know what other options there are that are more natural and safer. And so that's usually the case when a person contacts me and wants to do an interview and see if they would be a good candidate to come on board case management. My work is essentially a integrative oncology holistic practitioner focusing on terrain-based, meaning that dietary and lifestyle is the fundamental platform. And then I would coordinate different uh, modalities that would make the therapy very comprehensive. And I'm using advanced technology using the RGCC system, and that's the Research Genetic Cancer Center, which is an advanced laboratory biotech company that is able to give me the information I need to make a therapy very much personalized, specific for a person's cancer, and be able to use that and integrate it with what they're already receiving, whether it's integrative oncology or whether it is a conventional oncology. It's just a combination of things that are implemented to help this person uh, fight cancer and hopefully get a very successful outcome to the point of maybe even achieve remission, whether it's a stage one or stage four. It really doesn't matter as long as the therapy is designed to be very personalized and removing all the guesswork as much as possible, which the RGCC system enables uh, me to be able to create that kind of personalized therapy. So I've been using the system since 2018, and prior to that, I've been trained in my background as a Gerson practitioner way back in 2012 when I officially started seeing cancer cases, uh, helping in dietary and lifestyle medicine and combining it with a metabolic therapy protocol that helps to increase the person's metabolism and help to reverse a disease process. And most of the cases I saw uh, was cancer, and it became uh, uh, more and more specialized, not just seeing other non-cancer cases. And so I just ended up doing more and more cancer case management, and then eventually it's just specializing in cancer therapy. So here I'm going to um, be showing you a case that I do, which is really quite similar in pattern when I'm doing a work to manage a case of any cancer type, but this is one that will be breast cancer. So usually what happens is when a person gets diagnosed with breast cancer uh, by oncology, they will be given uh, options on what kind of therapy they would recommend. And so commonly it's either going to be breast surgery, that would be a mastectomy or a lumpectomy. It could be a chemo treatment first or after surgery. It could be including radiation. There may be a hormone blocking medication as well, and maybe even uh, potentially off-label drugs if it is an integrative oncology center that's managing a case. But whatever that the situation is, that usually in conventional oncology, you're looking at surgery, chemo, radiotherapy, um, and targeted therapy like hormone blocking meds, and that's pretty much the typical recommendation. And then the client looks things up in the internet and does some research and discovers other natural approaches and do a consult with um, that type of approach to see if there's other options or anything that can be added on to make the therapy more robust and comprehensive, because a lot of times the conventional approach is not going to deal with the complete cancer care. It may help to stop temporarily or put a person in a temporary no evidence of disease, or whether it's a small residual disease. It's usually uh, just to keep it under control, and even if it goes into remission, usually years later, even 10 to 15 years later, the cancer comes back. And and when it comes back, it's usually quite advanced, even stage 4, and it's all over the body. And so it's then much more difficult to manage because the cancer has been uh, thriving all along and gradually increasing in their numbers. And so it's quite late in that sense to try to bring it back to a no evidence of disease status. So so what happens is after a uh, recommendation of treatment, when I see a case, they've already been told this is what they're going to receive, some chemo treatment, or they'll start with surgery first and then chemo, followed by radiation, and then maybe a hormone blocker. There's different protocols that the oncologist is able to decide what's the best way to approach it. And a lot of it is guided by the standard of care protocols. And so when I see the case, I will determine first what's the baseline metrics that I need. And so I would request for RGCC testing, which is usually the Oncotrace and the Onconomics Plus. The Oncotrace will be able to provide me with the initial circulating tumor cell count, which is the CTC number. That will be used as the baseline measurement so that any future testing then will be compared to the baseline. And we want to see a decreasing circulating tumor cell concentration. That's that's the cancer cells that are circulating in whole blood in the person's bloodstream, and that number of concentrated concentration of cancer cells reflects what's actually in the person's body, the tissue where it came from. So the tumor actually releases or disseminates these cancer cells into the bloodstream, and over time, these numbers are increasing. And once it's in the bloodstream, it's just a matter of time where it will migrate and invade tissue. And so that's how metastasis occurs. Without the circulating tumor cells, there's really no way where it can metastasize. It has to be in circulation to go to other sites around the body. From one primary area to another area, it has to be in the bloodstream. And so the concentration of these cells, the number of cells per unit volume in breast cancer, it's cells per 7.5 mils of blood. That's the unit used when we're measuring the cancer cells. So, for example, if it's 4 cells per 7.5 mils, that's the concentration of an active disease as a baseline starting point. And so the OncoTrace will give me the information of the number of circulating tumor cells as a starting point, and then about every 4 to 5 months approximately, we'll repeat that test to see the change in the concentration, and it needs to be decreasing rather than increasing, because decreasing down towards zero is the goal of a practitioner who's using the RGCC system, because when it's close to zero, then the activity is significantly reduced, and that's what's reflected in the tissue where the tumor is at, and whether it is visible or not visible, because a scan can only have a certain level of detection. Anything below that, they're not able to see it. Anything less than 3 millimeters or 2 millimeters, it's really hard to know what that is. It's indeterminate. However, when we run the blood test to look at the circulating tumor cells, we're already seeing a certain concentration. So we're able to detect much earlier than what a scan can detect. So once I establish the initial number of circulating tumor cells, then I also look at the phenotype markers. The phenotype markers, which I will show you a document to show you what that is. The phenotype markers are able uh, to provide the associated source of this cancer cells, their behavior that's based on the type of protein surface markers on the circulating tumor cells. And the behavior can be either highly metastatic or less metastatic. It could be high in relapse risk, high in resistance to treatment risk. Those are the most important uh, behavior of that we need to assess, because that will make us determine what would be the best strategy in addressing this case and creating a specific plan. And so if it's very aggressive, which means high resistance, high relapse risk, high metastatic risk, then it would be very important to make sure that this person has already consulted with oncology, because we need to approach it in a very comprehensive way so that the cancer cells the first time around will be significantly reduced to a very low number, and and that way there's less chance of a new generation of cancer cells that will be way stronger. Those that have escaped from being destroyed the first time around will be much stronger, more resistant, and that's why uh, if a person is receiving several lines of chemo. One line of chemo, maybe 6 rounds. And then after that, if things aren't looking significantly better, they will likely switch it to another line of chemo, a different drug, and that would be considered second line of another 6 or more cycles. And so after several lines of chemo, that person's body has been weakened significantly. And at the same time, the cancer cells that survive are way stronger, much more resistant, and there is much less likelihood for this person to even consider achieving a no evidence of disease status or potential even to be in remission. It's much more difficult to achieve that after several lines of chemo. So it's the first one that's the most important, and it needs to be comprehensive, which means that it would be concurrent with integrative and holistic therapies at the same time, not necessarily the same day, but the same time period combined together to maximize the reduction of disease load or tumor load by inhibiting and destroying the cancer cells that are remaining. And so that's kind of what I do. I essentially coordinate all these different therapies, and the main thing is that I know the inside information because I have this comprehensive data to use and to be able to create a very specific approach and very effective personalized therapy approach. So the OncoTrace test is the one that helps me determine the baseline concentration of circulating tumor cells, and then the uh, phenotype markers to give me the current behavior of the current circulating tumor cells in order for me to create a specific therapy strategy. And from then on, I would be monitoring after therapy starts. I would be monitoring this test and repeating it about every 4 months. And then we'll be able to see how well they responded to the comprehensive uh, integrative therapy along with oncology care. If that's usually the case when I see uh, cancer uh, cancer cases. It's usually a combination of care. All right, so and of course, when things are combined, you're more likely to get the best outcome because you're not allowing the cancer cells to run away or escape from another route that's not covered. And so by adding different types of therapies, combining it even with the conventional oncology, you're limiting their escape routes because you're attacking the cancer cells from all angles at the same time or same period of time. And so it's really much more difficult for cancer to survive that. And that's why the success potential is really high when you have a comprehensive care approach. And of course, we try to limit the uh, uh, the collateral damage from cytotoxic agents like the chemo drugs. And so if the person only gets one line of chemo, or in some cases in the integrative oncology care, they sometimes use the IPT or insulin potentiated therapy, low dose chemo, which only uses like 10% of what a normal chemo drug would be as far as dosing. But regardless, whether it's IPT low dose or conventional regular dose chemo, if a person only gets one line of chemo, that that is usually the most opportunity that a person can get out of it if it's combined with the RGCC system of integrative care, because we're using very specific agents that shows a high efficacy, very high sensitivity focus on that particular cancer with a high kill rate and inhibition of growth. And so the next test that is included for the baseline, besides the OncoTrace, is the Onconomics Plus. Now, the Onconomics Plus is uh, the uh, the test that essentially uh, will will harvest the circulating tumor cells, and then it will be cultured in a 3D hydrogel media with specific growth factors that's only for that type of cancer, and uh, the biological environment is very similar to what a person, what's happening in a person. And so it is not like the old days where you're only doing 2D cultures, and that's not representative of what it's like in the body. So 3D culture and sensitivity testing is way, way more advanced. I worked in the lab for 5 years as a medical technologist, and we do a lot of culture and sensitivity on in the uh, microbiology, and this is nothing compared to that. They're using very advanced technology, and lots of these methodologies are actually proprietary, and they're not going to share that information with other companies that are trying to compete. So there's only a certain amount of information you can get from understanding what's done. So essentially, the culture and sensitivity test in the Onconomics Plus will test about 150 plus agents. These are a combination of drugs uh, that are chemo drugs, monoclonal antibodies, uh, small molecular weight drugs. These are like the hormone blockers, tamoxifen, for example, that's an estrogen blocker. For the monoclonal antibodies, that can include immunotherapies like Keytruda or Opdivo. Those are very popular immunotherapy drugs. That's all under monoclonal antibodies. And of course, the chemo drugs are classified in different types. There's alkylating agents, there's uh, inhibitors of topoisomerase 1 and 2. There's nucleoside analog. So you'll see that when I share the a typical a report of an Onconomics Plus. Now, on top of that, it also tests for some off-label drugs like ivermectin, um, doxycycline. That's an antibiotic. So there are some off-label drugs that show significant effect against cancer cells. And so those are routinely tested. That's the doxycycline and the ivermectin. Then we have also the natural agents. And the natural agents are like vitamin C, melatonin, Boswellia serrata, uh, agaricus, which is a mushroom extract, a sea cucumber extract. There's uh, even low dose naltrexone, or naltrexone is tested. Um, and so there's just so many natural agents uh, tested that are under the class one, two, and three. Class one are the cytotoxic, class two are the immunomodulators or immunostimulants, and the class three are the protein kinase inhibitors or metabolic pathway inhibitors. And so the natural substances are divided and tested within those three categories. And so there's over 50 of them. So by the time we get the results, there's just so many that we can choose from. And we, of course, select the ones with the highest kill rate or the highest sensitivity or efficacy and create a specific treatment plan for that. And so that's the Onconomics Plus. And along with that, it also does a separate test, which is the transcriptomic microarray. And that's a molecular assay that will determine the gene expression of the circulating tumor cells. And there's approximately it's an 80 plus 80 to 85 tumor related genes. These are the validated tumor related genes that uh, that reflects from that specific type of cancer. And so these cancer cells or the circulating tumor cells, their gene profile is shown in the report. And that way we will know which ones are are the highest expression or abnormally expressed that the cancer cells are using for it to grow and proliferate. And what we do is the RGCC practitioner is able to determine the pathways that can be blocked by either natural agents or sometimes off-label drugs. And so we'll use the natural agents then that shows high efficacy or high sensitivity in terms of percentage. We're going to pick the highest ones and create a treatment plan for this client, and selecting those natural agents, and then combining that with what oncology is already recommending, and hopefully what the oncologist recommends is one that shows high efficacy too in the test. But it's not always the case. However, most of the time it is at least partial sensitivity and not necessarily high sensitivity. But that's good enough for oncology to be able to get some control over the cancer. And we doing from the RGCC system of sensitivity testing, we're able to be more selective and create a plan that removes the guesswork, and combining that with the oncology. And of course, the outcome will be significantly way better than just oncology alone. So that's the Onconomics Plus. So combining the gene profile and then the sensitivity gives us the information necessary to eliminate the guesswork of what works the best. So that's the baseline. I have the OncoTrace test and then the Onconomics Plus, and then I create first the platform that the person is going to be following is a specific dietary platform. It could be a plant-based, or it could be mixed plant-based and animal-based, but generally the plant-based gives a much better outcome for those who can handle it, because it is much more supportive for reversing many types of diseases, not just cancer, but heart disease, diabetes, and so forth. So on top of that platform, I will add on the specific agents that are shown as high efficacy or high sensitivity, very effective against the cancer cells, having that knowledge in advance, and then creating that therapy plan, and then explaining it to the client at the meeting, so that way they can get started and doing it in conjunction with the oncology care. So today I'm going to share with you a spreadsheet of this person in her mid-40s, and this person has a stage 1 grade 3 left breast cancer, invasive ductal carcinoma, estrogen and progesterone receptor positive, HER2 negative, with a Ki 6 to 7 of 25%. And this was a recurrent breast cancer in her left chest wall area, around the area where she had originally had a lumpectomy back in 2017. And so that was the initial. At that time, it was only a grade 2. And this time when it came back, fortunately, it was still in the same area of the left breast. And it was then grade 3 when it had recurred. And that was back in 2020. So a mere 3 years after it was removed, and initially, and then they did an oncotype test. The oncology did oncotype test, and it showed that she didn't really need any more treatment other than the surgery. No chemo recommended, and they sent her home with tamoxifen, which is for her premenopausal condition. That's the choice of hormone blockade, is tamoxifen. So she had a surgery, It was actually a mastectomy, not lumpectomy, a left breast mastectomy in 2017, then prescribed with tamoxifen and sent home. And they said they got it all, margins clear. And like I said, the oncotype did not uh, show that she needed any chemo treatment. Okay, so that's that. And then when I saw her for the first time, it was 2020. So right around the time when she uh, had her surgery, that's when we met for the first time to do the initial consult about a month later. And so I'm going to show you a spreadsheet. I'm going to share it here on the screen. Okay, that's not it. Let's try it one more time. I have several displays here, so I'm going to make sure I'm the right display. Here we go. So here's a spreadsheet that I'm going to show you. This is where I enter the data of the type of cancer, left breast, grade 3, stage 1, invasive ductal carcinoma, ER/PR positive, HER2 negative, and Ki-67 up 25%. And the original diagnosis was a stage 1, and that was 3 years prior. And at that time, it was also the same in that was the original hormone receptor positive and HER2 negative. And then in 2020, when the cancer came back, that was grade 3, and in the same area, left chest wall, and that time it had a ER positive at 91 to 100%. So it's quite pretty much the same in terms of the cancer, the hormone receptor status, and the Ki-67 is still considered high at 25%. That has to do with aggressiveness or mitotic ability. And so that's not considered good when it's anything 25% or more. Generally, that's not a good situation. So at that time, uh, the oncologist recommended that she should go on chemo treatments. But before doing that, she decided to do a consult, and I saw her in December of 2020, and the baseline shows here that she had a 4.1 circulating tumor cell. That's the baseline count. And that was done, the test was released in January 7, and that was a 4.1 circulating tumor cell. And that's cells per 7.5 mils concentration. And then what I do is I look at the phenotype markers here, and it shows that the specific one that I'm looking at is the OKT4 and SOX2. These are markers that I'm monitoring too, that tells me this person has a very aggressive behavior cancer that is high in resistance and a high in relapse risk. Of course, the oncologist does not have this information and does not know that behavior based on these cancer markers, which are the cancer stem cell markers. And then, of course, what I do is I track it, because over time, if any of these markers downgrade, then that's also a significant change in behavior. And so anyway, you can see here that the cancer cell concentration is gradually decreasing over time. And I'm usually testing about every 4 to 5 months. And there are some months that I didn't retest, as this person, based on her schedule, sometimes it goes beyond what I would recommend as that should have had a follow-up. But again, we're able to keep going over time to see that this person's cancer concentration is decreasing gradually. And this time, one time it went up higher than where it was when we were getting close to 2, and then it jumped up to 3.8, and that's almost back to square one. But sometimes the cancer will develop a more resistance. It's fighting, and you can see that it is not responding to therapy as well when you're seeing an increase in the circulating tumor cell concentration. And so I would have to make some adjustment to the program to either to increase the doses or retest. But whatever that I do, I want to make sure that it's coming back down, which in this case, it went back down from 3.8 to 2.6 cells per 7.5 mils. And it continued to come down, and then it went back up again. So this person had some bumps along the way, but overall, we got it down to a much safer level. And it took a few years to do that. We're finally down at 2 and last year, September, and she's due for another test. So for a follow-up. So it should be less than 2 by now, which is really a very good number because statistically, anything that's less than 2, and, and as a as from experience, generally it is much more in the territory where remission level becomes achievable, either remission or stability of very low disease activity or no evidence of disease. If a scan was done and the cell count is less than 2, that would be essentially typical for a remission territory. So she's right at that point in time where she is essentially very stable and much lower risk. And in just a few more months, we can probably see that to be less than 2. So, so this is a typical results of the OncoTrace. And then we've got the Onconomics Plus below that shows the gene profile. And so anything that is red is really not a good situation because it means that it is high expression, and it's either it's supporting the disease in proliferation, progression, and so I have to interpret this to determine what the cancer is using the most favored pathway, and then we will be selecting agents that will either downregulate these overexpressed metabolic pathways because these genes will encode to the protein pathways when they translate to protein expression from messenger RNA. Then these overexpressed metabolic pathways need to be downregulated by some type of agent, and that's of course the ones that are showing high efficacy in the sensitivity testing. So that helps us to create a plan that will knock down or downregulate these genes that are overexpressed. And essentially, the goal is to turn off the cancer genes or bring it down close to normal. Or normal is 0, of course, but sometimes it's not necessarily easy to turn all the genes to become normal, but there's sometimes you will see a lot of genes become normal. In this case, you can see there's quite a bit of resistance in this genes because they're showing lots of overexpressed genes, the ones that are in red. So again, you can have a very high risk gene profile, but with a very low number of circulating tumor cells. And as long as it correlates with a negative scan or a stable scan, that's generally much more favorable and potential for overall long survival or be able to get into a remission level is more likely to occur as long as it's less than 2 cells per mil. But this has taken approximately, you can see here, just about close to 5 years to achieve that. that number because it's a long haul. Cancers are smart cells. You try to destroy it, and then the surviving ones are getting stronger. But as long as you stay on top of it and be able to do the sensitivity testing every year with the Onconomics Plus, you'll be able to select the best agents that are showing sensitive, because usually after 6 to 9 months, the agents that showed high efficacy are no longer sensitive. Down below here, you'll see the changes in the hormone sensitivity. So you can see that this person initially started with tamoxifen, but then decided we will go with what the RGCC test showed. The fulvestrant in the baseline Onconomics showed a 20% sensitivity, which is considered high efficacy, with over 5% being effective. And so at 20%, that's what the Faslodex or fulvestrant showed, which is a estrogen blocker. And so that was good, whereas the tamoxifen did not show that much efficacy. As you can see here, you'll see that tamoxifen only showed a 10% sensitivity, just above the 5%, which is still effective, but not as effective when it's 20%. So the fulvestrant was chosen by the client who relayed that to her oncologist, and he agreed that was fine to use fulvestrant and also to switch it to fulvestrant. Also, she also went on exemestane, which is the an aromatase inhibitor, and that combination with fulvestrant, 15%, that's effective, and so that helped to address the hormone receptor positive circulating tumor cells and to reduce or downregulate that pathway that the cancer is depending on as one of many pathways. As you saw here, all these red highlights are different metabolic pathways. The estrogen hormone receptor pathway is just one of them. And you can see here, the estrogen receptor at the baseline was 30% overexpressed, and it started to drop down over time to 10%. And then, of course, it can fluctuate. The last one showed 10% still. So nothing like the baseline that used to be at 30%. So the goal, of course, is to not be dependent on estrogen as a pathway for the cancer. And of course, the other pathways too need to be down regulated. So she was on fulvestrant and exemestane, and since she's not menopausal or postmenopausal, she was put on Zoladex, which essentially will help that situation because she's put on a menopause status. So now at this point, I will show you the natural agents here that showed high efficacy. You can see the agaricus, the ascorbic acid, which is the vitamin C. And so all these agents here that are showing high efficacy, I can create a plan out of those and add that to her program. That is on top of her terrain-based therapy, which would be specific dietary modification that is anti-cancer, plant-based in her case, and then also with the metabolic supplements to increase metabolism in order for more energy production, and the energy is necessary when you're promoting disease reversal using a whole food concept and supplement support. So that's just the fundamental platform, and then on top of that, we add the anti-cancer agents showing high efficacy based on the RGCC test results. So that's the spreadsheet, and you can see over time these sensitivities can change. And what used to be sensitive sometimes turns off or drops down significantly. Like here, it was 25, and now then it was 15, and then later it comes back to 20. That's 9 to 12 months later. So every time we do a onconomics, we have to reselect agents because the ones that used to be very sensitive are now not very sensitive and or not at all sensitive. So we have to create a new plan each time we do an onconomics plus. And like I said, the onconomics plus is repeated every 9 to 12 months. Every 9 months if it's highly aggressive, and 12 months if it's just the typical, not very aggressive, but just the ones that we usually do are usually every year. But in some cases, the highly aggressive ones, we do it much earlier, like 9 months and sometimes even 6 months. And so we're able to select the agents and include that with the oncology drugs. In her case, she's taking only now she's only taking the fulvestrant, Zoladex, and then the exemestane aromatase inhibitor. Initially, when she started, we selected a chemo drug that showed a really high efficacy. That was 82%. And that's Xeloda. That's a chemo, oral chemo. And the reason we selected that is because of her grade 3 high risk situation of a recurrence. We decided that it would be best for her to discuss it with her oncologist. And so he was willing to give it a try. We tried the capecitabine, and it has an 82% efficacy, which is really high. Over 80 is what we want to see. And so we chose a good one. However, it was very toxic. It sent her to ICU for about 2 weeks because of the toxicity, and she recovered. But that was enough to significantly give her leverage against the cancer cells, and we were able to finish off with no further chemo at all. That was just one time, one dose, and it was too strong, and it sent her to ICU. But that, fortunately, was enough to get her cancer under control, and we were able to bring it down. Um, and I believe that that was a good leverage. And then the rest of them are the targeted drugs, along with the natural agents that we selected from the Onconomics Plus natural substances. So her latest now is down to 2 cells per 7.5 mils, starting from 4.1 baseline. So that's significantly downgraded, and now much better to control. And essentially, she's just a few months away, and once it's less than 2, then she can just remain there as long as possible. And of course, the scans need to be correlating this. There's no other unusual or suspicious lesions out there that if they're encapsulated, we can detect that. But in this case, she is doing really well, and her last imaging was done in 2024, last May in 2024, actually 2 years ago. And back then, she only had a small nodule of 4 millimeters, and it was a pulmonary nodule. It only increased by 2 millimeters when compared to a year and a half prior, when they did the same CT chest without contrast. And that time it was just 2 millimeters and stable 2 millimeters subpleural. And then this time around, it increased to 4 millimeters. But again, in a year and a half with a 2 millimeter change, and everything else is looking pretty good. They're just observing and just monitoring, but essentially there's really nothing else going on, and her circulating tumor cell count is decreasing. And so that increase in size could be anything, could be infection, inflammation, and so we don't really know what that is. We'll just have to observe it and monitor. But again, she's already over 5 years since the initial care that we started. So she's doing extremely well. Right, so I'm going to share with you her latest UNCO, let's see, her latest report. Let me just unshare it for a second here. I'm going to show you that this is when it was the baseline. I'm going to put this on the screen so you can see her baseline CTC concentration. At that time, the format of reporting was a little bit different, but here's the CD45 negative cells, non-hematologic origin. This is the solid tumor category, and this is the hematological malignancy category. So we're looking at solid tumor, breast origin with this MUC-1 that's positive, and that's associated with a breast origin. And then this is the cancer stem cell marker that are showing positive for both markers on the surface of the CTC that indicates that it is it's highly aggressive. And so I'm going to share with you where it's at currently. And again, there's different ways to interpret because the behavior is just one of the information that tells me the tumor activity, but the behavior, which is the what it's trying to do right now. But the number is also very important because if it's below a certain cutoff, then it doesn't matter if the behavior is still aggressive, as long as the number is really low, then we have a much better chance of achieving stability of the disease or have an opportunity to move towards a remission territory. So I'm going to share with you the most current report on that. That was on the spreadsheet, but I'm going to show you how it looks like on an actual report. And so, and we did the Onconomics Plus, and this may be the last time to do the Onconomics Plus because once it's below 2 cells per 7.5 mils, we're just going to monitor it a yearly OncoTrace test to make sure the number remains there. All right, so I'm going to share the Onconomics Plus report here. So you can see that for this person, 2 cells per mil, the latest, the baseline was 4.1 in 2021. And the prior to this 2, it was 2.1. So it's definitely slowing down. And that's why I ordered the Onconomics Plus, because we need to reassess sensitivity since I can see that it's starting to plateau. And that means that many of the agents are no longer sensitive and need to be reselected. And that's why the Onconomics Plus was the right test to order. So these are chemo drugs that are showing what works. But again, this person is not on chemo, so that this is just additional data in case this same person had a reactivity and it's starting to get aggressive. Then if a chemo is selected, it will be the ones that show high efficacy. But these are genes that are showing high resistance factors, which means that we have to apply approaches that are going to circumvent or reduce this resistance in order for us to have a more effective therapy. So we know what we have to do when there's a high MDR1 or high MRP. These are the multi-drug resistance factors. And you can see here that the small molecular weight drugs, the exemestane is near the lower limit of 5%. So it still works, but it's not great, but it still works. The higher percentage, of course, the better. Okay, so these are genes that are showing it's downregulated. So it's no longer a real issue unless it is overexpressed, and then that would be means that it's using that metabolic pathway for proliferation or increased proliferative activity. You can see the estrogen receptor right here. It's weak. It's not really high expression as originally at 30%. So this is a weak estrogen receptor. Okay, so all these are genes that are overexpressed, and these are we are going to try to downregulate these genes using natural agents that show high efficacy. And by blocking as many metabolic pathways, it's much more difficult for cancer to proliferate or grow, because they're using a lot of these metabolic pathways for their support in growth and proliferation. So we can actually focus and cut off their pathways at the same time using agents that are also sensitive when it's in contact with cancer. So we're cutting off their pathways, we're exposing them to cytotoxic natural agents. And as you can see here, butyric acid is really high in terms of sensitivity. So that's effective. Okay, and so these are the inhibitors. And you can see CoQ10 is really high in sensitivity. Okay, so that's a typical Onconomics Plus format report that I analyze and create a new therapy protocol that will include the high efficacy agents. And so this person is very pleased with her improvement, and is now essentially in a remission, or at least nearing that remission territory. I'm very happy for her. It took a long time, and she's very pleased. And so that's the topic on the breast cancer case. And next month, again, the second Tuesday of each month, we'll cover a different type of cancer, and we'll cover prostate cancer next month. Our date will be May 12, Tuesday at 8 p.m. Central Time. Thank you again for attending this this podcast, and any comments you have, you can send it to Ask Dr. Miven. That's AskDr Miven, MIVEN, at protonmail.com, and that I will be able to answer your questions if you have any questions, or you can send it also to another email address that it's drdonato@pm.me. That's also my main email, secure email, if you have questions. Thank you very much for attending, and I appreciate it, and have a good rest of the week. Bye-bye.